End-of-life care has been challenging for a long time in the developed world and particularly in the United States. In 1987, we published a major framework to guide decision-making in this area. In fact, that framework was cited many years later in the case of Nancy Beth Cruzan, which was the U.S. Supreme Court decision that confirmed the right of patients to refuse unwanted treatments near the end of life. And it also affirmed the importance of advanced care planning. So that framework from '87 has been incredibly influential in determining what's ethically and legally permissible in the United States. And it's been emulated in many other countries as well and helped to shape their own frameworks. Since '87, when those came out, there's been 2.5 decades of important empirical research and new policy work. The basic foundation has been affirmed in those 25 years, but we've learned an awful lot more about how best to put that framework into practice. And so we thought it would be an important service to be able to synthesize both the empirical literature and the policy work. And so we are delighted that we're going to be releasing a new, updated, enhanced edition that synthesizes all of that work. The topics we are taking up now are ones that have not been taken up before. I'm very, very proud that we are addressing the very difficult and trying decisions that clinicians and, most importantly, parents face when they're making decisions about the use of life-sustaining treatments for gravely ill children and adolescents. We've also made it a point to reach out to people from the disabilities community and make sure that their views have been reflected in our guidelines and are informing our recommendations. And that is very new. Disabilities advocates have not really had as big a voice in these conversations as we wanted to be sure that they did. Another way it's different is that in this 25 or so years since the first publication of our guidelines, we now know a lot more about the way in which our healthcare system as a whole needs to change, how we have to better coordinate care, how we have to establish more teamwork, how we have to cross boundaries between the long-term care setting and the acute care setting. And so in addition to our original guidelines is a look at how this all figures with healthcare reform. Doctors are trained to offer technologies and to manage those technologies, and very often they bring benefits. But it's not always the case that they bring benefits. They also bring burdens. We perform CPR, cardiopulmonary resuscitation, on many people for whom it really cannot provide benefit, but because it's available, it's offered. And it's offered because nobody is having a conversation with the patient and the family about the longer-term trajectory of the illness, about the likely prognosis, and helping them see what may be in store for them. We need to have very nuanced and sophisticated conversations with patients who are gravely ill and help them understand their circumstances. We know that when that's done well, both patients and families are grateful. We also know it's difficult, and it's difficult for clinicians to hold those kinds of conversations. They don't have adequate training to do so. The guidelines also address the communication skills that they need and how they can get them. If we're going to see continued progress, many people have to do things within their own spheres of influence. We hope journalists will take these guidelines and help to promulgate them and interrogate them and figure out ways to have them make a difference. Of course, clinicians have to make them their own. Healthcare administrators, policymakers, a whole bevy of people in different kinds of roles in our society have the ability to make a difference, and we hope these resources will be of use to them as they do that.